So let's get started with today's clinical topic. Our speaker today is Dr. Stephen Gold. He's a graduate of USC Dental School, and he was full-time private practice in Southern California for 16 years before he transitioned to the wonderful world of academia. And he is currently an assistant professor and the coordinator of digital dentistry at Western University College of Dental Medicine in nearby Pomona. His topic today is conservative tooth preparation. And I think this is an area that was kind of out of favor for many years, mostly because of the challenges of temporization. But now with the growing use and predictability of in-office fabrication methods, it's making a well-deserved comeback. So I'm anxious to learn more, and I'm excited to turn this over to Dr. Stephen Gold. It's all yours, Stephen.
Thank you very much, Dr. Park. Just want to say an honor to be here as part of this program this morning, such a distinguished panel to kick things off. Just really want to thank Glidewell for inviting me to be part of this. I've been in Southern California for most of my dental career, and Glidewell's been right in my backyard, particularly over the last year or so in doing some of these educational programs with them. They've treated me like nothing less than an extended family member. And so really mean that from the heart and truly appreciative of the opportunity. So thank you, Dr. Park and Nicole and everybody at Glidewell. And thank you to all the attendees this morning who are joining from wherever you are. I'm going to get right into things because I love talking about tooth preparation, and 40 minutes is going to go by fairly quickly. So you're looking here at a tooth. Obviously, this is a patient that I treated quite some years back. One of the first patients I treated with CAD/CAM when I was learning how to use that technology. And, I learned how to do conservative dentistry when I was in dental school, but I realized that not everybody learns that. I speak to dental students around the country. Some places just don't teach it or don't emphasize conservative tooth preparations as much. It was for me. So I look at this tooth and, although I could treat this with a full crown, I really don't want to for a couple of reasons. One, while there is a broken cusp, and obviously this tooth is in need of some treatment, there's a pretty small restoration in the tooth and a lot of good tooth structure remaining. The other thing that I notice about this is that if you look on the buccal of this tooth, we have a little bit of gingival recession and a non-carious lesion. And I don't know about all of you, but one of the things I really hate is trying to prepare a good tooth margin and then capture it, whether it's in an impression or a scan, anywhere down in an area like this. So if I can do something conservative and treat this tooth and take care of the problem and protect it, prevent it from, further damage down the road. If I can do that conservatively, I'm going to do that. I'll show you the tooth preparation that I use for this tooth a little bit later on. I just want to say that this is a sort of an abbreviated version of some presentations that I do. Glidewell does have an on-demand course. If you want a little more detail, you're welcome to take a look at that. And I give this presentation at some meetings around the country. I'll be in New York at the Greater New York Dental Meeting if you want to see this in a little more detail. But hopefully today this gives you a nice overview of some of the details. We're gonna really dive into the get into the weeds here of some details of tooth preparation again, which I love. So I don't have time today to give you my full public service announcement on preventing enamel cruelty, but just suffice to say, when you look at these teeth that are prepared for full crowns, the one thing that I think of, and I don't know the situation behind any of these, some of them may have needed it, but my assumption is that probably many of them did not need a full coverage crown. And so what do I think of? I think of thousands, maybe even hundreds of thousands of destroyed enamel rods that were just senselessly lost their life, in the process of doing a full coverage crown. And so, I'm glad that you're with me today, and I hope you'll join me in this, this journey that I'm on, this mission to help prevent enamel cruelty. Let's see if we can put an end or at least minimize full coverage crowns and do things that are much more conservative and save those precious enamel rods. from an untimely death there. My disclosure, I am receiving an honorarium for this presentation today from Glidewell. Neither Glidewell nor any other company has had any input into nor influence over the content of my presentation, and I don't have any other affiliations, paid or otherwise, with other commercial entities. All dentistry you see was performed by me unless I specified otherwise, and the photographs are unretouched. What you see is what you get and what I actually did. So our learning objectives, I first want to describe how conservative tooth preparations can lead to better restorations and long-term tooth health. I'll show you a little bit of scientific evidence. The bulk of the presentation, I'm going to show you this process and how to synthesize all the information that we have, about the tooth and really customize a preparation and a restoration for the given condition that tooth presents with. And then lastly, how to use CAD/CAM design system to check tooth preparations and improve the quality of your preps. So first thing, just a little bit of definition. When I say conservative, as I alluded to, we mean something less than a full coverage crown. Okay. A lot of these restorations will fall under the category of an onlay, but they may not look like traditional onlays where you're covering all the cusps of a tooth. There may be part of the restoration is an inlay, part of it's an onlay, so you can call these inlays onlays. I've heard that, other terms out there. If you're a CEREC person, they like this term crown lay, which I really don't like. But they're basically onlays. The point is that they're conservative. We're gonna remove as little tooth structure as possible to do the job needed and spare those precious enamel rods. The other thing that's important is that we're talking about bonded restorations. So these restorations are going to be retained to the tooth with adhesive dentistry. And that does affect how we think about the preparation and the fact that we don't really need to incorporate retentive features into our preparation as we would say for like a PFM if we're not bonding it. And you'll see how that plays in to our preparation process in a little bit. Okay, I don't want to bludgeon you all with extensive evidence today, but I do want to point out, I think it's always intuitive, or at least it has been to me, and I think many of us, that it's better when we conserve tooth structure. It's better for the patient. But I went in and I looked at the literature to say, how exactly is it better? And the answer is that there's a lot of different ways. So number one, the fracture resistance of teeth is better. They're less likely to fracture the less tooth we take away. And again, that sort of makes intuitive sense. I'll roll through these pretty quickly. The strength of and the survival of the restoration itself is better when we do more conservative type of restorations. The periodontal health can be better. If you think about it, when you'll see a lot of these restorations are going to have margins that are supragingival. So we know when we have a subgingival or even an equigingival margin that we change that bacterial flora, and not for the better in the sulcus, and that can lead to periodontal breakdown. So keeping those margins up and away from the tissue whenever possible is going to lead to better periodontal health. The actual strength of the restoration is better. When you have a smaller restoration, a more conservative restoration, those restorations are less likely to undergo fracture. Okay, and there's some evidence to that. This is an interesting study, actually not with indirect restorations, with direct composites. But when you place an interproximal restoration on a tooth, not only are you creating an interproximal margin of that restoration, a lot of times, at or subgingival, and that we know that margin is not going to last forever. It's going to be susceptible to bacteria and breakdown and recurrent caries. But this study shows that you're also putting the adjacent tooth, even if you don't prep that tooth, you're putting the adjacent tooth at increased risk for caries. So you'll see with some of these preparations, when we can really be conservative, we may not even need to extend the restoration into both interproximal surfaces, and that can help the adjacent teeth as well. And lastly, we see that with more conservative tooth preparations, the bond strength between the restoration and the tooth is actually better. And there may be a number of reasons for this, but I think the main one is, and you'll see that one of our goals in conservative tooth preparation is to try to preserve, as we said, as much enamel as possible. So if you can maintain an enamel margin as much around the preparation as possible, even in 2023, with all the advances in adhesive dentistry, we would still rather bond to enamel any day of the week than to dentin. So the more conservative preps with enamel margins, super gingival, where you can manage them and isolate things easier, leads to better bond strength between the restoration and the tooth. Okay, so we're going to get into the actual criteria of the tooth preparation. And I have, this is what I use when I teach my students here. And it's basically all the criteria of the prep and kind of a checklist. It's supposed to be easy, it's something that beginning tooth preparers can kind of understand. It's a simple checklist where if you have this in your preparation, you check yes. If you can check every single box, then you have a satisfactory, a clinically acceptable tooth preparation. I did forward this, and I think Nicole has said she will email this to all the attendees so you can refer to this. It does have the criteria and, again, some of the measurements. So please refer to that and use this at as much as you want to. Okay, so I'm going to talk about, kind of go into each of these criteria in detail. I've categorized these by the 4 main criteria that we use to teach tooth preparations. If you've been out of dental school for a while or you haven't been immersed in it like I am on a daily basis, you maybe have forgotten some of these terms, but every tooth preparation has an outline. It has internal features. We have a cavo-surface margin, and we have retention. So I'm going to go through each of these 4 and talk about what are the criteria needed for a good clinically acceptable, conservative tooth preparation for a bonded restoration. So the first thing we want to do when we have a tooth like this, and I think we could probably all look at this situation and see this tooth has some problems and can probably benefit from a good indirect restoration. Got a multitude of different restorations in here, have some recurrent caries and breaking down of the restoration and the distal. And there was a time in my career when I would be doing, say like a PFM crown for this, because let's say the patient wanted something that was tooth colored. And for a lot of dentists who typically will default to a full crown as the restoration of choice, you could easily go in, clean out all this junk and build it up, or just start prepping all these walls for a full crown. But what I want you to think about now when we look at this is, okay, if you take away the restoration, there's still a lot of good, healthy tooth structure out here and maybe over here, and maybe this tooth does not need a full crown. So we're going to go through a process to really look at what's going on in the tooth. And the first step of that is to do what we call circumscribe the existing restoration and caries. And if this term is something that, again, from back in the days of dental school, when you've forgotten about, circumscribing just means we're going to take out the restoration and the caries, and we're going to start to place a margin on good, healthy tooth structure. Okay, so whatever's going on in the tooth, we just want to get the preparation beyond that and get it on sound tooth structure just as a start. So you'll see here, I've almost got this circumscribed. Okay, we still have a little caries, recurrent caries at that mesial margin. So again, rather than prep away a lot of tooth, to circumscribe this, we're just going to drop that gingival margin until we're on healthy tooth structure. So first step, circumscribe it, okay? And then we're going to check if we don't already have separation from the adjacent tooth. We want to make sure that we do have some separation from the adjacent tooth so we can access and get a good, accurate impression, and also for cleaning up the restoration once it's cemented. So our minimal requirement or measurement that we teach is at least a 0.5 millimeter of separation from the adjacent tooth for that purpose. So again, we're going to now extend the preparation to achieve that. Okay, and then at this point, we can start to look at how strong are the remaining cusps of these teeth, because we're really going to be conservative, and sometimes you might have cusps that are strong enough and that don't need to be covered by the restoration. So one of the criteria we're going to look at is how thick is that cusp in this area at the base of the cusp. Okay, so we can't always exactly measure that, but we want to estimate that. And for a strong cusp, we want at least 2 millimeters of tooth structure. Okay, so if it's anything less than that, we're going to deem that cusp is weak, and we're going to cover that in the preparation and cover it with the restoration. If there's more than 2 millimeters of tooth structure, then we might be able to keep that cusp and not include it as part of the restoration. If you're wondering where that 2 millimeters comes from, there is some evidence. There's a nice study that shows when cusps are less than 2 millimeters, that the risk for that cusp fracturing increases dramatically. So that 2 millimeters is sort of a guideline. And this is kind of how you would, if you could magically get in there and measure that with say, a caliper, this is what we're talking about. The thickness of the cusp at the base, okay? So as you're developing these preps, again, you might have at least part of the prep be kind of an inlay. So we create this, what's called an isthmus, the distance between the two walls of the preparation. And there's a minimum requirement for that. Usually this is for strength of the restorative material. So again, we want at least 2 millimeters. So if we have say a narrow restoration, it's less than that. We want to widen the prep to achieve at least 2 millimeters of an isthmus there. Okay, moving on. Further criteria for the outline. If we have margins of the restoration on the occlusal surface, we want to make sure that finish line, the junction between the restoration and the tooth, is not at the point where we have occlusal contacts with the opposing tooth. So you want to check that, make sure that those occlusal contacts are not at the finish line. If you're developing a prep and there's a contact right at the finish line, now we need to extend the prep to move that contact off of the finish line and onto the restoration. Okay, so no occlusal contacts on the finish line of these restorations. All right, by the same token, we don't want to have a finish line going right through a cusp tip. So in this tooth, as we're kind of cleaning it out and I'm looking at this lingual cusp to see, is this strong enough to keep? When we include this little erosion lesion, we're going to get very close to that cusp tip. So if that finish line goes through the cusp tip, we're going to deem that cusp weak, and now we're going to cover it, we're going to reduce it and include it in the restoration. So this is sort of the process of going through, and what we're really customizing is the outline of the preparation to what the tooth has in its existing condition. And we're sort of taking all those factors into consideration, making sure we treat the tooth, cover weakened cusp, but leave as much tooth structure as possible. Okay, so moving on to the category of internal. So these are features like reduction amounts. A lot of these are determined actually by the material that you're going to be using. So with all the vast array of dental materials we have out there now, manufacturers may have their own recommendations for how much to reduce. And I would say definitely follow those recommendations. I teach dental students who are at the beginning of their career, and we want to kind of keep things simple. So I teach reduction guidelines that will work probably for most materials, because we can't ask beginning dental students to remember, 5 or 10 different materials. So these guidelines will work for pretty much any material. The first one is when you're developing the prep is this pulpal depth, okay? So we want a minimum of 2 millimeters pulpal depth. And if you'll see where the arrow is indicating, the pulpal depth is the measurement from the deepest part of the occlusal groove down to the pulpal floor. Okay, so we're not measuring the depth of the wall, because most teeth have cusp slopes. Usually this wall is going to read greater. But if you think about the reason for reduction is strength of the restoration, we want to know where's that restoration going to be the thinnest. And it's right here in the central groove. So I'll show you how we guarantee that we have the proper reduction in the central groove there. When we have to reduce cusps, we're going to go ahead and we teach 1.5 millimeters on non-functional cusp and 2 millimeters reduction on functional cusp. Okay. And then we don't always have a shoulder finish line on these preps, but when we do, we call this the axial depth of the preparation. We want that to be a minimum of 1 to 1.5 millimeters. Okay, further criteria. For indirect restorations, preps obviously have to have some taper so the restoration will fit into the tooth. So we want to try to maintain about a minimum of 10 degrees of taper so those restorations fit really passively. And we also want internally nice, smooth, and rounded line angles. Okay, and this is true of any type of bonded restoration. Sharp angles can concentrate stresses in the material and can lead to premature fracturing of the restoration. And if we're going to fabricate these out of CAD/CAM technology, we also know that the burrs can't recreate sharp angles internally. So nice, smooth, really well-rounded internal angles of the prep. And then we'll move on to the cavo surface. So this diagram you see is directly out of courtesy of Ivoclar or Evident for EMAX, and they recommend a shoulder or deep chamfer. What we teach is 90-degree exit angles, because as you'll see, we don't always have a shoulder finish line in our preparation. If we're reducing cusps, sometimes we may have sort of like this flat occlusal reduction that just comes straight out. So 90-degree exit angles. Sometimes have dentists say, I kind of get confused. Well, what's the angle we're looking at? It's the angle between the finish line, the exit surface of the preparation, and the external surface of the tooth. So we teach that that's 90 degrees. So in a shoulder preparation, there's the 90-degree exit angle. And that's really to maintain and guarantee that you have a bulk of material at the margin of the preparation, and it reduces the chance of fracturing. I don't have time to talk about this today. There are some variations on this, and some dentists do like to advocate putting a little, a small bevel here. But what we want to try to avoid are like knife edge margins where that restorative material gets really thin. And so to maximize the bulk of the restorative material, the 90-degree exit angles will do it. Here's showing how we typically will prepare the tooth, and you'll see this again later in the video that I have. So holding the burr kind of on a horizontal there will give you those 90-degree exit angles. These preparations can get a little bit complicated when you start really customizing them. So here's one where you can see I've reduced cusp on this side of the tooth. This side of the tooth, these cusps were strong, so we didn't have to reduce them. What this results in is lots of exit angles. So like where these proximal walls exit the tooth, we want to make sure those are 90 degrees. And where you have these walls that sort of exit out on the buccal and lingual, we want to make sure that those are 90 degrees also. Okay, so 90-degree exit angles all over the preparation to maximize the bulk of restorative material to reduce the chance of it fracturing. That's the reason for that. Okay, and the last category is retention. And I've already alluded to the fact that we are retaining these restorations onto the tooth via bonding. So we don't really consider or incorporate retentive features into the prep, okay? And we can say that that's true most of the time. So unlike a PFM where, we need certain wall height of the preparation to retain the restoration to the tooth, for these bonded restorations, we're saying you don't need a certain wall height. And so you'll see a lot of these preps end up looking, by the time you have the reduction and round everything off, they almost look very flat. They have very little, if any, mechanical retention because we're going to rely on adhesively bonding these restorations to the tooth. Okay, so talk a little bit about kind of getting more into, you talked about the criteria there. What are we looking for in the finished prep? We're going to go a little more into the technique here. I first just want to quickly talk about burrs. Again, I get paid absolutely nothing from Brasseler. We do use Brasseler burrs at school. And this is the burr kit that I like for these bonded restorative preps. And I'll just walk you through quickly kind of what the burrs are. These are from Brasseler's Bob Winter, prosthodontist. You may know Bob. His line of burrs, which I really like, they work well to achieve those features we need in our preps. So going from left to right, I have a couple of depth guide burrs here. We have a 1.5 and a 2 millimeter depth cutting burr. And as you'll see, one of the features I really love about preps and guaranteeing that we get the right amount of reduction is depth cuts. And so these are the burrs we would use for those depth cuts. Moving then to the right, we have some tapered burrs. These are flat on the end, and then they are rounded at the corners. If you look in this little detailed version, these are rounded here to avoid those sharp internal angles, but flat-ended to give us that 90-degree exit angle that we want in the prep. I have two different sizes on this burr block. I think what I've done is I'm kind of a burr geek. Like if I had all my burrs, that I really wanted maybe during a prep, it might get, to like 20 or 30 or some ridiculous amount of burrs. So I have to constantly remind myself to simplify things. You pick the size that you want. I think we picked this one here, which is a little closer to about 1 millimeter wide at the diameter. I do like having this burr here. This is a little bit shorter, but wider at the tip, about a 1.5 millimeter width there. And it's really good for getting nice, smooth pulpal floors and even finish lines on the buccal or lingual where you have access to using that. Good for rounding off those internal line angles to make sure they're all well rounded, not leaving anything sharp. And then lastly, on the end, is sort of this football shaped burr, kind of an egg shape. And this again is good for rounding off internal line angles and just making sure that we don't have any sharp angles there. The other thing that you'll notice is I do have these burrs, the tapered burrs, in both a medium grit and a fine grit. And I started recommending some years back coming and finishing at least all of the margins of the prep with fine grit diamonds. My colleague, Alan Atlas, some of you may have heard him speak. He showed some nice evidence that was done, some studies that show that when you finish preparations and you leave it with a regular grit diamond or even a carbide burr, that you leave all these little micro cracks in the enamel, and fine and super fine grit diamonds sort of eliminate those. So we think that these micro cracks that develop, like this one you see here, over time, these become, mega cracks and can cause, premature marginal breakdown. So I'm recommending going back and finishing all margins now with a fine grit diamond. So that's why you see those on the burr block. Again, not going to go into detail with this, but you are going to see it in some of these preps, how to enhance the preparations, as I call it, with adhesive dentistry. And there's a couple things we can do. If you like the process of immediate dentin sealing, we're going to basically etch and seal the dentin. We're going to use composite quite a bit. You'll see in some of the preps I do for not only blocking out undercuts in the prep, but also basing things up. I'm a big believer when you have, say, a deeper preparation and irregular pulpal floor due to caries or restoration, and basing that up to the ideal level so you have a nice smooth preparation. And I love this topic. We kind of do this another day, talk about proximal box elevation, which is a little bit controversial, but again, is a technique that we have to bring margins super gingival using composite if needed. Okay, so we're going to go through, have a little video here to show what this process looks like kind of in a simulated tooth condition. So here's a tooth, got a restoration, as you can see here, a fractured cusp, great candidate for an indirect restoration of some sort. We're going to try to do this conservatively. So first thing I want to do is check the occlusion and see where those contacts are, because remember, I don't want any contacts, margins of the restoration where those occlusal contacts are. And now we're going to go in and start circumscribing the restoration and caries. Now I would use a depth cutting burr for this, but I'm using a burr of known depth, and I'm doing this at a depth of 2 millimeters because I want that reference point. If I go in and completely remove the restoration, I could end up with a big hole in the tooth, and I sort of lose track of how deep that pulpal floor is. So now I'm checking that proximal separation that I mentioned. We want to get at least a 0.5 millimeter. So I'm going to do this conservatively. I'm just going to extend that buccal and lingual proximal wall of the prep to just get that proximal separation. And now that I have a reference point of the pulpal floor here being at 2 millimeters, now I can go in and remove any more restoration and caries if there's anything there, any defective tooth. And I'm going to get deeper than 2 millimeters, but I have that reference point. So now at this point, we're going to look at remaining cusp and remaining tooth structure. I'm going to first here check that isthmus width, and you'll see back here at this distal, that isthmus is a little less than 2 millimeters. So I'm going to take that tapered diamond again and just open that up and get 2 millimeters. And I'm also creating these tapered walls, so divergent occlusal walls. Going to look and make sure those angles are all round. There's a sharp angle that would be very difficult to reproduce, especially if we're fabricating these from CAD/CAM. So I'm going to round that off. We're going to look where that fracture was on the lingual surface. Okay, that edge was left a little rough there. So rather than prepare the whole tooth, we're just going to drop the finish line down in that area using that flat-ended, rounded at the corners burr there to create a 90-degree exit angle, a shoulder, but with an internally rounded angle there. You'll notice I'm leaving all these other cusps for now, but now we're going to check and see, okay, what's weak on this tooth? What needs to be covered? So there's a mesial buccal cusp with a big undercut, distal buccal with a little less of one. And we have, again, that photo showing, here's what we're looking for, less than 2 millimeters of thickness at the base of that cusp means it's weakened. So now we're going to go in and just reduce that weakened cusp. So all these other cusps are strong, that marginal ridge is thick, so I'm not even going to drop or extend the preparation to the distal. So I'm putting a depth cut here to make sure I have the right amount of reduction. Again, I use a depth cutting burr now. I think at the time I made this video, I was just using another burr of known depth there. Reducing the cusp, and you'll see the angle that I'm holding the handpiece at to achieve that 90-degree exit angle. Going to go back and double check all the taper of these walls, to make sure we have draw. These preps can get a little more complicated than, say, a full coverage crown. Got walls going in every different direction. So even with the tapered burr, I just want to make sure I have that minimum 10-degree taper. Burrs taper about 6 degrees. So you'll see me kind of leaning the burr into each of those walls just to provide a little bit more taper, making sure those restorations seat very passively. Okay, coming in and rounding all these line angles off. So there's a sharp angle between that pulpal axial wall there. I'm using that football diamond to come in and make sure that's rounded. One thing that I've evolved with over time is my preps are really a lot more rounded today than they were even like 5 or 10 years ago. So now we're gonna we go in and we're gonna do two things here: immediate dent and sealing, and then we're gonna base up that pulpal floor that got a little deep. So we have good isolation going through. We happen to use Optibond, if you recognize the tubes there. We'll apply our primer or adhesive, and we're really just concerned about the dentin. I get a little sloppy here. Obviously got a little on the enamel, but we'll clean that up later. Now you can come in with composite, whatever your choice of build-up material. If you like, any of the reinforced composites, if you like flowable, this is just regular restorative. I believe it's Kerr Herculite composite. Basing that pulpal floor back up to 2 millimeters, so it's a nice even depth all the way across. Had a little undercut there and a couple areas at the base of that distal buccal cusp. And so we're going to cure that. And then now come in and we want to finish, we want to remove any resin, whether it's composite or any of the adhesive off of the enamel margins. Okay. So you'll see I got some there on that gingival shoulder, on the lingual as it wraps to the mesial, because we want the final restoration to bond to enamel. Okay. We really want to preserve that enamel bond. That's what we're relying on. And there it is, a final prep, completely customized to what the tooth had. You know, these preps all look very unique, and no two really look alike. They'll have some similar features, but that's really what we're looking for. I'm going to stop the video here, but basically what it continues on, I just go through and for my students to show how we can check each of those criteria on that checklist to make sure our prep meets all of those criteria. Well, we're going to move on here, and I'm going to show you that last learning objective is how can we use CAD/CAM technology to make our preps better. So this preparation style, I think, will work for anytime we're doing a bonded indirect restoration, you know, whether it's ceramic, whether it's a composite material. But I'm a big advocate of CAD/CAM. I've been using it for the last at least 10 to 13 years in my own patients. I know it's a big part of practices out there. Not everybody's using it. So if there happens to be anybody who is, you know, kind of thinking of maybe going to CAD/CAM, just take a look at some of the advantages of using CAD/CAM chairside to really, in our case today, evaluate our preps and make them better. You know, you can really get a good look at the finish line, make sure that it's nice and clean all the way around. A great way to evaluate if you have any undercuts in the prep, to check and make sure we have the proper amount of reduction, both occlusally and the pulpal floor, axially, and also to look at the occlusal contacts and do we have any on the finish line. So again, here's a typical prep that we might develop here. Got a couple cusps covered on this maxillary molar, some of them not covered. These preps get complicated. So the first thing we can do, we can make this super big, you know, just enlarge that scan and really get a good look. I think most dentists who use CAD/CAM now in their practice will tell you CAD/CAM makes your dentistry better. And I totally agree with that. I just sort of broke it down here into what we look at. You know, you can really see, I teach my students to look down the walls of your prep. Make sure you can see all those walls when looking from the occlusal surface, just to really make sure you have no undercuts, make sure that restoration is going to seat passively. So if I were to go back and do anything with this prep, I might make a little more taper on that mesial box there, maybe on this buccal wall. Okay. Now, when you get two scans and you can actually mount them together, now we can really look at the occlusal clearance. Okay. This, by the way, happens to be Romexis Plan Mecca software, which is what we use in our school. But a lot of the softwares have this feature. You know, you can see the number by the cursor there telling us what our reduction is. But mostly we can just look visually from a lot of angles there. Look all the way through that prep and really make sure that we have the right amount of reduction. And sometimes with these preps, especially when you keep the buccal cusp, this view, you can never see this in the mouth, right? I always had a hard time seeing those lingual cusps. Do I have enough reduction on the lingual? Well, if you get scans and you mount them properly, you align the bite, we can just flip that around and really ensure that we have proper reduction, even on that hard to see lingual side. We can look and check and see where our occlusal contacts are. And then if we need to, we can go back and, you know, we can actually fix the prep. If anything's needed, we can erase that. Here in just a moment. I do these videos at the pace for dental students. So yeah, we can go back if we want to fix any part of the prep. A lot of these softwares have these features. You don't even need to redo the entire scan. You can come in, basically just erase the preparation, go back and fix what you need. The scans really give us a good targeted view. I'm under reduced on the mesial lingual cusp and the buccal surface. I can go in and reduce right in that area. Just do it really quickly, chair side. You know, you can't really do this when you take when you take just physical impressions. So this is immediate feedback and just a way to really make the preps better. So I'm going to go ahead and move on here. And just to summarize, there's some things you can only do digitally with scans. So again, immediate evaluation of the model. We don't have to take time to let an impression set pour it up. We just get the scan and we can look at it almost immediately and start evaluating the prep. Of course, you can enlarge it and really see features in that preparation that you just can't see clinically in the mouth. You can add the scan. So, if you get a scan, you can check the data. I didn't get that buccal margin. You just pick up the scanner and go right back and you can add to it. You just can't do that with a physical impression. As we said, if you don't like the scan, you can delete it. You can start over. You can delete parts of the scan and come back and fill it in. And you can, as we just showed, use it to really take a good critical look at your preparation and modify it if needed, and then come back and rescan the prep or fill that in. So to me, like using digital dentistry and the power of a digital scan just makes the dentistry better. It makes these preps better. It leads to fewer remakes. You don't get a restoration that doesn't fit. You can change things right on the spot. So if you can't tell, I'm a big advocate, and I don't think I could do dentistry anywhere near as well as I could without the power of a digital scan. Okay, so I'm going to show you. This is that tooth I showed you earlier, and again, I look at this, and now I'm already thinking I don't want to do a full crown here if possible. So here's what the preparation ended up looking like for this tooth. Okay, took out the restoration. This lingual cusp, again, was thick enough here. I had no occlusal contacts at the margin, so I was able to actually preserve and keep the lingual cusp. On the buccal, had that little rough edge of that fracture. Again, if any way I don't have to prep down in this area, I'm going to avoid it. So basically came in, you can see, just put a nice shoulder in that area. The fracture already gave me the proper amount of reduction, so I didn't need to reduce anymore. And that's the preparation. These can be very simple. They can take very little actual clinical time to do in the right situation. I think with this one have show you the final restoration there. Okay. Here's a tooth that we did in our clinic. This was done by at the time fourth year dental student. So again, even just looking, before we do any treatment, yeah, there's some problems with the tooth, recurrent caries, a big filling. Great candidate for some sort of an indirect restoration. If you're in the habit of just defaulting and doing a full crown on this tooth, again, that's fine. You can certainly do a great full crown, but can we be more conservative? So first thing, mark the occlusal contacts, because we don't want occlusion on the margin of the restoration. This is a great example. I want to just shout out to now Dr. Anoop Pandit, who did this preparation. Great example of what a tooth looks like when we've circumscribed everything. Okay, so he's at the right pulpal depth. Notice there's still some base here that needs to be removed, but we're just establishing sort of a reference point here in these areas. Okay, this is the depth we want the pulpal floor to be at the end. And he's done a good job of circumscribing, placing that finish line for right now on sound tooth structure. So now we can go in and evaluate, all right, how many of those cusps do we need to cover in the prep? Okay, again, we want to be conservative, but okay, there's, again, just showing the pulpal floor depth. We decided for this tooth, for a number of reasons, we're just going to cover all those cusps. Okay, they were weakened. So we're going to cover them. We do our reduction. Again, these are depth cuts made with those the Winter Series depth cutting burrs. 2 millimeters on these buccal cusps, which are functional, 1.5 on the non-functional. We're going to connect all that, get some cusp reduction here. That pulpal floor, once we removed all that base, was a little bit deeper. So Anoop's going to go in under good isolation now. We have etching. We use our Octobond system that we use, little composite to base that up, using the reference point, rounding everything off, and we're pretty much at a final preparation there. So you can see, like on this buccal view, we just leave that 90-degree exit angle. Okay, that's going to be the finish line of the preparation. Margins way up above the tissue. We can get, even though it's the last tooth in the mouth, we can get a rubber dam clamp on for proper isolation, for cementing this restoration here, and got a nice result there. I think we have time. We'll do one more quick example here. Again, kind of common situation, big restoration. This was a ceramic inlay, fractured cusp. Again, these non-carious lesions, if I can avoid a margin anywhere in or near that, I will do it every day of the week and twice on Sunday if needed. Hopefully I'm not going in on Sunday to do this, but clean the restoration out. I'm kind of looking at that lingual cusp. I think it's going to need to be covered, but sort of evaluating it. Got out, this is a transilluminating light because I noticed that this cusp has a little fracture in it. So again, there could be a number of reasons why a cusp is defective and needs to be covered. As soon as we saw that, we're like, that cusp needs to go. This was one of those, maybe some of you have experienced this when you have a fracture, a partial fracture in the tooth, and you get a burr, you just barely touch the burr to the tip of the cusp, and the cusp fractures off there. So now the reduction is done, thanks to the fracture. I just go in and clean it up, put a nice smooth finish line there, make sure all those surfaces are rounded, and that's the prep. Again, very mechanically non-retentive. If we weren't bonding the restoration to the tooth, it would never stay on. This doesn't work for, you know, any kind of prep where you're not relying on adhesive dentistry, but it was able to keep, again, those enamel margins, if not 360 degrees around the tooth, certainly close to it, enough that I can be pretty comfortable in knowing we're going to get a nice bond to the tooth there. All right, so just in conclusion, a couple of things. There's some studies that show conserving tooth structure, I should say, when preparing teeth leads to just better clinical outcomes for the patients in a lot of ways. This preparation process addresses the issues of the tooth. It takes care of the defective tooth structure, and we're protecting weakened parts of the tooth, preventing it, or at least minimizing the chance of future tooth fracture. You know, lastly, it's kind of using CAD/CAM technology really can help to evaluate the preps, make your preparations better, make your dentistry all around better. Well, you really start paying attention to the details when you see your own dentistry magnified, you know, 10, 15 times or more on a screen. That's the extent of my content. If you care to follow me, I'm on Instagram at Western U Digital Dentistry. I always appreciate some new followers. I think if I can get about 10 more, I'll be up to maybe 30 followers by now. So thank you all for that.
Hey,
and,
excellent lecture, Dr. Gold. Excellent lecture. We had a lot of really nice comments, and we also got a lot of questions. So if you can hang around a few more minutes, let's go through some questions.
Absolutely.
So this first one is under the category, actually first two, category of elephant in the room. Okay. This doctor says, hey, I'm a big fan of inlays and onlays, but I've worked in 2 different practices where they told me not to do them because the lab fee is the same as a full crown and the insurance coverage is not as good. Want to comment on that?
Yeah, I wish I had an easy answer for things like that. And I do get that comment a lot. I think at the end of the day, if as dentists, I think, we should be able to really have the final say in what's best for our patients. And I know it can be tough, especially for new dentists. We were talking before and some comments about the student debt load that a lot of dentists leave dental school with. You may end up in practice situations where you may have an employer who puts those stipulations on you. And it can be a tough call. I would just hope that everyone eventually can transition into some sort of a situation where you can make the best call for your patients. And whether insurance pays for this or not, I was in practice for 16 years, and we tried to, as much as we could, create situations where we were making the final call for the patients. And I would tell patients, hey, we're gonna try to maximize your insurance benefits for this, but they may or may not cover it. And this is the fee for this service. And then you kind of put it in the patient's hands and let them decide, okay, well, I think it's worth it. I think those reasons are good enough, and I'm going to go forward. Or they may decide otherwise and do something different. So again, I don't mean to minimize it, because that is a tough situation. But I think at the end of the day, I would really hope that we all as dentists can sort of evolve ourselves into a situation where we can really be the ones, us and the patients, working together, co-deciding on what the best treatment for the patient really is.
I think that's a great response to that question, because it is a tough one, and I think your response makes a lot of sense. Dr. Gold, so are there any contraindications to partial coverage? In other words, oral hygiene or an occlusal scheme? Any times you can think of when they're better off with full coverage?
Sure. And again, I didn't specifically address that, but I do when I have a little more time. But for me, full coverage restorations on posterior teeth like this. Obviously, if you're retreating an existing full coverage restoration, the tooth structure is already gone. You're sort of committed to doing that. When that process that I showed, you may go through that process, and it actually may lead to a full coverage restoration. By the time you clean out caries or restorations on the buccal lingual surface, you might be close to a full coverage restoration as it is. And lastly, I would say certain fractures in teeth. So when you take out restoration, and I think this is a fairly common thing. Maybe all of us have seen this, where a tooth is cracked, and you take out a restoration, and maybe you see a crack across the pulpal floor, and you really just want to get the maximum amount of circumferential reinforcement of that tooth. Yes, prepping down as far as you can. I would still probably try to leave it supragingival if I could, but to maximize the circumferential coverage. So teeth with some fractures there.
How about root canal treated teeth, root canal molars, for example?
So interesting. And again, for those of us, of my generation, for sure, we learned that standard treatment for a posterior tooth that's had a root canal is a full crown. And it was, kind of hard for me to let go of that. But back on that slide where I showed that evidence, that very first one, the actual strength of the tooth, that study was done on endodontically treated teeth. And so even with endodontically treated teeth, the criteria is that we cover all the cusps, okay? And this is on that checklist. I believe it's like number 5 down on that list of outline. But an endodontically treated tooth, at the minimum, we want to cover the cusps, okay? And we want to create proximal separation from the adjacent tooth, which you can do by a box or what I call kind of a swoop in between the teeth there. And then, of course, sometimes these teeth are broken down, so caries may lead to something additional. But again, the studies show that those teeth are actually stronger than they are if we prepare for full coverage restorations.
Got it. I love this question. So how do you eliminate that J, that little lip on the margin and on the gingival surface? I saw, you were basically taking like a flat-ended diamond, but how do you keep from having that little lip?
Yeah, that's a great question, because it's such a common thing, especially, like when, so two things I would say. It depends on the burr, and that's why I like those flat-ended burrs. If you like a rounded-ended diamond, there is a little more of a risk of leaving that J, because that's just the shape of the burr. So I like the flat-ended diamond, and specifically what you really need to do as you're finishing up the margin. So this could even be with that fine grit diamond, which I really like to finish the margins, is you got to get just a little bit of that burr hanging over the edge of the margin to eliminate the J. So it does require enough, separation from the adjacent tooth, so you can do that without damaging the adjacent tooth. But it's just really getting in there and making sure that flat end just slightly hangs over the finish line, kind of out into space, so to speak, to eliminate that J. And the other thing I would say, which will help with that also, because it can be sometimes hard to identify, is getting a good digital scan if you can do it, and really turning it in all those different directions. So looking at those margins kind of from the side, which sometimes can be tough to do in the mouth, but looking at that and really critically evaluating it.
And you're so right. And you made such a great point that if you complete your prep and you do a scan and something's not right, it's just so easy to go back and fix it and then rescan that portion. It's just such a great way to practice. So I love the way that you made that point. It's
Well,
really
totally
great.
agree. And to hear that coming from, the largest dental lab in the world, which would love to have business and to advocate and recognize that, that the value of having a chairside digital scan in that way is, says something as well.
Yeah. Okay, here's an interesting question. So you're not really making your preparation for retention because you're using adhesive, reactions to do that. Why do you have to have a 2mm pulpal floor?
Yeah, good question. So, the first part is, and I generalize some things here. There may be a situation where maybe we feel the bonding might be, in some way compromised, or we just might feel a little more comfortable with some mechanical retention. So by all means, if you feel that in a preparation, you just want a little extra retention, you want to drop a margin down to create some walls, that's totally fine. And I think you should do that as part of clinical judgment. So the second part of it is, the question was, why 2mm of pulpal depth? That's pretty much exclusively for the bulk of the final restoration. So you have a proper thickness. The number one method of failure of bonded restorations for years, and it still remains, is fracture. And a lot of times the reason things fracture is inadequate reduction, and so not enough thickness of the final restorative material. So that's the real reason for that 2mm of pulpal depth is to really guarantee that final restoration has proper thickness.
I'm so glad you made that point because, a real good indicator of fracture toughness is how thick that material is. And the thinner it is, the quicker it's going to fracture. And I think 2mm is a great recommendation. So thank you. All right, here's the tough one. You ready?
Okay, I think so.
Okay. So in my introduction, I said to you that these kinds of restorations are making a comeback because of CAD/CAM and in-office milling, things like that. So then we got a bunch of questions about temporization. You're not putting any retention in these things. No. So how do you how do you temporize them, or do you temporize them?
Yeah, and so a couple of things too. First, to answer the first question, do you temporize them? For those dentists out there, and I know there's a lot of them using CAD/CAM in office, a lot of times no need for temporization if you're doing these restorations same day. So if you're looking for another sort of a check mark or reason why, hey, how can CAD/CAM help, is exactly that. I'm in a dental school, and so the one truism about dental schools that has been the case since I was in dental school and even before is things move really at a glacial pace. So very infrequently actually are we able to do same day restorations. So almost always temporizing these. It can be tricky. I'll just say that right up front, regardless of what technique you use. So if we have a preparation where we have some occlusal walls, where part of the preparation is an inlay, sometimes you can take advantage of that. And now we have some retention. So a material like Fermit, which we use at our school, is something quick and easy. You can just sort of pack it in that and cure it. It kind of stays a little bit soft, so it's easy to remove later on. That can work when you have a little bit of mechanical retention. Some of those preps, like I showed you, like a Noops prep that was pretty much flat. We temporized that, and I like the technique of spot etching. So going in and you are going to have to bond that provisional to the tooth. The tricky part is to bond it just enough so it stays as long as you need it, but so it's easy to get off later on. And that's pretty much the answer is to spot bond that. A millimeter, maybe 2mm diameter of an etch, usually on the dentin surface, and then adhesively bonding it. And when we've done that, most of the time we find we can get the restorations off satisfactorily. Every once in a while, I can think of one patient some years back, that sucker was just bonded on, and I ended up having to get the handpiece out and take it off. But they're relatively infrequent. Probably more often the temporary might come off before the patient's next appointment. So I always, and even with temporaries, when we cement them, sometimes they come off, right? I mean, patients don't always take gentle care of their temporaries, and so I just tell them, hey, if that thing comes off, come in right away and let's re-cement that. So the answer is, when you have some retention, You can sometimes utilize that to do more of a traditional temporary cemented or firm. It can be nice for smaller ones. When you really lack that mechanical retention, spot bonding.
Okay, I got three more and they're all good.
Oh, okay.
All right. You're doing an onlay prep, but the tooth also has some kind of a class 5 defect, like a buccal pit. Would you extend the preparation to include that, or would you make that maybe a separate direct restorative?
Yeah, and that's and saw I think there were at least those two examples of the patients I treated as premolars that had those class 5 kind of cervical, I like the term non-carious cervical lesion. And how do you treat that? And the answer is, as you saw, I typically don't extend the prep there because I think I can treat that. So sometimes they may not even need to be treated, depending on the situation, if there's sensitivity or if it bothers the patient. But if it needed to be treated, I'd try as much as possible to do it as a separate direct restoration. Again, because I just find oftentimes those cervical lesions, they're difficult to prep into. Sometimes at margin you have recession. So now you have a really long axial wall on the buccal surface. It can be hard to deal with, hard to get that taper, hard to get scans and impressions down, at or under the tissue. So as much as possible, I would do that as a separate direct restoration if we went through the process and determined the patient actually needed a restoration there.
Got it. Okay, we saw your bonding technique involved etching dentin. Are you concerned about post-op sensitivity when you etch dentin?
The short answer is no. I mean, we etch dentin all the time for any adhesive procedures. Don't typically get sensitivity. In fact, sometimes the opposite. And I don't know if there is any scientific studies to show this, but certainly anecdotally, I hear a lot from dentists when you do immediate dentin sealing. So you prep the tooth, you do basically the dentin bonding part of the prep at the time of the prep before the impression. And then maybe you temporize and the patient goes. A lot of times sealing the dentin off actually reduces, if not outright eliminates, sensitivity, because that's a lot of the sensitivity comes from open dentinal tubules. Okay, whether they're freshly cut and we've sort of irritated the pulp, or you have open dentinal tubules and a restoration that when the patient bites down is putting some hydrostatic pressure. Sealing those tubules off, etching and then applying primer and adhesive, and a lot of times it seems to eliminate the sensitivity, if not greatly reduce it.
Great. Okay, we did not talk about your selection of the restorative material, and obviously you didn't have an unlimited amount of time.
Right.
But I did get 3 or 4 questions about it. So can you just mention some of the materials that you use for cases like this?
Absolutely. Pretty much all the restorations you saw in my presentation are Emax, and that's sort of lithium disilicate, I should say. Now that there are other brands of lithium disilicate on the market, that has pretty much been our workhorse. It's sort of our workhorse material, especially when we do our in-house CAD/CAM at school. We have not ourselves done, and I personally haven't done a lot of these partial coverage restorations using zirconia, but I happen to know some dentists who do and love it, and they have great success with it. Obviously, it's a little different bonding process that's used with zirconia, so you have to really adhere to that. What I found is that lithium disilicate, again, when you go through the proper bonding technique, you really get excellent long-term material strength from that.
Right. We also are having a lot of success with camouflage, which is a highly filled composite material that mills beautifully and mills very, very quickly. And I know a lot of people. You'll see actually next week at our IO symposium that a lot of people really successful with partial coverage using camouflage.
Yeah, and you sort of took the words out of my mouth there, Neil. I was going to say, the composite, that's kind of in the other direction. Again, a little different bonding technique, not as strong of a fracture resistant strength. So I might avoid it if you got like a second molar you're treating, a patient with some heavy occlusion. I might steer a little more towards the smaller restorations and maybe more towards the, premolars and first molars. But totally agree. Got so many great material options these days, almost too many. And the answer is a lot of them will work and be successful with the right technique.
Dr. Stephen Gold, thank you so much for a wonderful lecture today. Your students at Western University are lucky to have a enthusiastic, committed, and thorough professional like you to teach them. And we are lucky to have you come on our webinar and present. So thank you very much. Thanks everyone for joining us today. We're going to be off again next week for our .io symposium. And then we'll see you back in 2 weeks when we'll have, as always, our business advisory panel. And our guest speaker will be Dr. Kyle Stanley. He's the Chief Clinical Officer of Pearl, and he will enlighten us about artificial intelligence in dentistry. So we'll see you back here in 2 weeks. Take care, everybody. Thanks again, Dr. Gold.
Bye-bye.
Thanks, Dr. Hochberg.
Dr. Gold was great.